This podcast is produced by the Center for Deployment Psychology at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of Defense, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of Defense, or the U.S. government. Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do. One colleague to another. Hello and welcome back to Practical for Your Practice. I am Jenna Ermold, one of the hosts of this series, joined today by the fabulous Dr. Kevin Holloway. How's it going, Kevin?
It's going well. Thanks for asking. How are you doing, Jenna?
I'm good. I feel really lucky to have our guest today, who is Dr. Deborah Glasofer. Yes, I'll say that again, Dr. Deborah Glasofer, who is joining us. How's it going, Debbie? Are you here?
I'm here. I'm delighted to be with you guys. Yeah, all is good.
Wonderful.
So good to have you.
It is. We're just going to start quickly by having you, we actually have you introduce yourself, maybe just tell our listeners a little about who you are and the work you do and where you're located would be great.
Sure. So I am a clinical psychologist. I'm an associate professor and clinical psychologist up at the New York State Psychiatric Institute and Columbia University's Medical Center. So I'm up in Washington Heights in New York City. And I work here in a research program where we are always recruiting people who are interested and eligible for research studies to try to help us learn more about eating disorders and their treatment. And I've been here now for about 15 years.
Excellent. Well, one of the reasons why we're excited to have you today is we are eager to help our listeners, and obviously we work with a lot of military-connected folks, and we don't have a lot of content on the assessment and treatment of eating disorders, and eating disorders is becoming an area of increased focus with the military as well. So thank you again for taking the time. Before we even keep going, one thing I think is important is we use this term eating disorders, sort of quote unquote, but I wonder if you could sort of start us out by describing what is the range of those disorders, what's included in that category, because I think a lot of folks, their brain immediately goes to anorexia and bulimia, which are the commonly known ones, but obviously there's sort of this larger group of disordered eating under that category.
Sure. So the most common eating disorder is actually neither anorexia nervosa nor bulimia nervosa, but binge eating disorder. And binge eating disorder is really characterized by having a frequent experience of feeling out of control when eating a really large amount of food. And having that be distressing. Often the eating looks a little bit different, might be faster, might involve shame or guilt. And this happens with some regularity. People can have binge eating disorder and be in all different size bodies. And that is one of the most common diagnostic categories. It shares features that idea of having a binge eating experience is shared by the diagnosis of bulimia nervosa, which you mentioned. And that's an eating disorder that involves, again, having that feeling of loss of control when eating large amounts of food, but also then compensating or getting rid of calories or food in some way in response to those binge eating episodes. And again, this is a pattern that plays out, at least weekly for people with this diagnosis. Anorexia nervosa is a category where we're thinking about folks who are really, sitting at too low a weight, a significantly low weight. They're often quite fearful of gaining weight or becoming fat and have a bit of a distorted sense of how they look, or really lack of awareness about how medically and psychologically serious it is, how many complications can arise from being at a low weight. Some people don't realize that people can carry a diagnosis of anorexia nervosa, and some of them also have binge purge episodes. But if the person is sitting at that low weight, we would think of that as part of anorexia nervosa, because a piece of the treatment has to be improving your nutritional status. Let's see. The other eating disorder that involves highly restrictive eating was introduced into our category in the DSM just in DSM-5. So it's been around about 10 years, and we know a bit less about it. And that is avoidant restrictive food intake disorder. Shorthand is ARFID. This, it can affect adults. It also more commonly affects children. And that's really where there's a highly restrictive diet that's causing nutritional problems or social problems. But people with this diagnosis are not over concerned about their appearance, about their body shape or their weight. They're simply, for any number of reasons, having difficulty taking in enough food. And then, there are some other disorders that I think are a little bit less researched, which I'll mention just by name, which is pica and rumination disorder. And then we've got our category of other specified feeding and eating disorders. And those are catch-alls, which include things like people who have symptoms of bulimia or binge eating disorder, but maybe not engaging in those behaviors as frequently. It includes a diagnosis called night eating syndrome, where people really struggle with just what it sounds like eating the majority of their calories at the night. And then I do want to highlight a diagnosis or a category within this other category that I think is important for people out there to know about, and that's currently titled atypical anorexia nervosa. And there's some very good arguments about whether that is a well-named condition for the moment or not. But this is meant to capture people who are really experiencing all of the same psychological symptoms as someone with anorexia nervosa, and they've experienced a significant reduction in weight, but they're underweight for their own body's needs and may not be sort of classically, quote unquote, low weight if you're using a BMI criteria, but their brains and bodies are in a state of starvation, and weight loss was involved in getting them there. So I think it's really important, and I could imagine especially important for military providers to know about. And there's been a lot of interest in the field in the diagnosis and a lot of research going on. So hopefully we'll know more about who these folks are and what can help them.
That's fascinating. I think, like Jenna said, right, many of us who are not as well steeped in the research and such hear the term eating disorder and think of like one or two things. And it's fascinating that there's really a lot of different ways that can present. And as you were describing them, it seemed to me like there were a couple of things that seemed to stand out as maybe some commonalities, and maybe you can kind of correct me on this a little bit too. Like some feels like there are some that have a feeling of a lack of control and as part of it. Some feel like over controlled for various reasons and other ways. And I don't know if that's necessarily one way that eating disorders kind of hold together, but are there some kind of commonalities, common features or mechanisms underlying a lot of these eating disorders, or I don't know how you would even kind of think about that.
Yeah, so I think absolutely you pick up on one really important feature of several of the disorders share this idea of an experience of loss of control while eating. Many of the disorders are really share a feature which I think of as like dietary restraint, which could be cognitive or could be behavioral. So this might be someone having a diet mindset, which for one individual leads to a lot of rule-bound eating and a scary drop in weight, and for somebody else leads to binge eating episodes, right? But that shared feature of that goal of cutting back or limiting types or amounts of food. Yeah. And then I think these disorders carry a lot of guilt, shame, or fear around eating what I would again put in air quotes, like outside the rules, whatever those rules are. And, and then like many of our other psychiatric diagnoses, in order to actually, right, like meet criteria for these problems, this stuff has to be causing a problem in your day-to-day life.
Sure.
And with eating disorders, I think, people have a lot of questions often about like what's disordered eating and what's an eating disorder. And we live in a culture where many people diet, and how do you know the difference? And yeah, sometimes we're looking for clearly dangerous behaviors, right? Like purging, for example. Sometimes we're looking for it to kind of get you into trouble where your weight sits. But also we're looking at like, are you able to be in your life, and do things like, participate in a family meal at a holiday, and be able to be flexible and eat adequately on a day that you have a long flight and you got to find something at the airport. And, that's what we think of sometimes in this field around day-to-day functioning.
Yeah. Well, as a follow-up too, you mentioned the air quotes, right? The rules, eating within or without the rules. And it made me kind of in my head think about the aspect of social pressures or expectations or certainly, perceptions thereof, how they impact. And I wonder if you could say something about that with regards to maybe how these things hold together or not, how these different disorders might, I don't know, kind of hold together or not with regards to how social influences are part of it.
Well, I mean, I think the social influences are just so interesting. I mean, the rates of eating disorders with the last couple years, potentially as an exception, have been pretty stable. And these problems have been around for a long time in a lot of different cultural contexts. So whether there was one fad diet or another fad diet, or whether it was looking at videos or, on TikTok or selfies on Facebook, or magazines from the 1950s, right? Like these things all play a role, but they don't tell the whole story. You asked about mechanism a few minutes ago, and I think it is important to say, like, these are brain-based problems which have some complex relationship with our environment. And there are lots of thoughts in this field about how biology and the environment might interface, but people have to be vulnerable, biologically vulnerable in the first place. So whereas I would say, unfortunately, we live in a culture where like 99% of people diet, many, many fewer than that will develop an eating disorder. So there's something different going on in terms of vulnerability. Unfortunately, for those who develop these problems, they're very serious, and they carry a lot of medical complexity and complications and risk beyond even the psychological risk.
I think that that's such an important point. And it's interesting to think sort of back on the history of, what's going on in the world and the rates of eating disorders, and that they've been pretty stable. And you alluded to this idea that maybe there was a little bit of a shift in the past couple of years. And I'm curious, kind of looking at, again, the environment and things that are going on impacting rates. And again, I'm not well informed on this, but I have some understanding that there was an increase in rates in eating disorders over COVID. And I may be right or wrong on that. You can correct me again, but what was the impact of COVID on eating disorders?
COVID had a tremendous impact on eating disorders. So what we saw was worldwide rates of hospitalization and presentation for treatment went way up. And this was especially true for young people, for pediatric and adolescent populations. And it was also quite true for those with restrictive eating disorders. But it really was, unfortunately, like replicatable around the world. And I think there's a bunch of hypotheses for why we might have seen this increase. So it could be that there was simply a change in resources available. So as outpatient clinics closed or intensive outpatient programs went fully remote, that led to this offset where more people then showed up for a presentation for hospitalization, whether COVID just environmentally, set something off where we're seeing a different severity or an earlier onset, or just different numbers, is a little bit unclear. Any of these certainly seem possible. One of the things I'll just add is, beyond looking at hospitalization rates and presentation for treatment, there was more of a mixed picture on people's symptoms, like during what I call acute COVID, like during lockdown,
Interesting.
Yeah, for sure.
Yeah, where many people did unfortunately deteriorate. They experienced, just under the stress, like more binge eating, more hypervigilance about physical activity, more of a scarcity mindset related to food resources when people were unsure what would be at the market or when they'd be able to, when it would be safe to go get food. But there also were people who improved, right? That there was something about a structure that supported a normal eating pattern. If you lived, some people living with others had more support and supervision around meals. So the picture is a little bit nuanced, but when we look at those hospitalization rates, for sure, something was going on.
That's interesting. And I think one of the concerns, or one of the, from talking to some folks in this field, is sort of the paucity of training, that a lot of our behavioral healthcare providers,
Absolutely.
a lot of our healthcare providers, this isn't an area where they have sort of this robust amount of training or sort of a really well-informed, well-supported and supervised. And I think that's one of the amazing things that your group is doing, is really trying to close that gap, trying to figure out sort of, novel ways to support providers. And I'm hoping you can share a little bit about what you're working on, which is a training series for healthcare providers to do a better job and support them better. Can you tell us a little more about that?
Yeah, I'm really excited to be able to share it with you today. I'm going to start by answering your question about like why it's so important. Eating disorders, the topic is just not robustly covered in medical training. So, there have been studies showing, that maybe less than 2 hours is spent on the topic across years of medical school, that many medical schools, don't teach much about it at all, that when you look at the level of residency or fellowship, or depending on what the clinical degree is, that next step in the professional journey, that people kind of show up, and if they wind up working with someone with an eating disorder, they're not all that comfortable, because they haven't had much exposure to either the knowledge or people with these problems. And that there are downstream effects to this. So when you start to look at generalists who are further along in their career, that they're not all that confident in their ability to diagnose a specific eating disorder, to clinically manage the issue, or to even, sort of know where to refer, like what treatment options are recommended. So, I'm very fortunate to work with a group, as I mentioned at the outset, that's really interested in research and education and filling gaps of all sorts in this field. And my colleague, Evelyn, Attia, and I got especially interested in trying to level the playing field so that we could increase access to care, regardless of someone's, geography, and regardless of what kind of training they, signed up for or what school they landed at. And so we decided to develop an online program, which we called PreparED. And we really felt, and we're hardly the only people to feel this way, that there's an opportunity to leverage where we are with technology today to increase access and, we're learning in all kinds of environments beyond a classroom these days. So we developed this resource. It's available at a website that's prepared.nyspi.org. It's modular, so it's flexible and brief. The modules are like anywhere from 15 to 30 minutes. They cover topics including eating disorders diagnosis, medical complications, risk factors, treatment, not how to do the treatment, but what to know about the treatment, how eating disorders do and do not overlap with obesity, and so on. We tried to make it engaging. We got a lot of, we got a lot of feedback from different stakeholders, from students, from educators, from people at all different places in their career. It's got some quizzes in it, so you can sort of check that you're learning and get some feedback from it. And it's got a bunch of resources that are downloadable, so you can go in once, download them, and kind of have them for reference for the future. So that is what I'm hoping is the beginning of our innovative solution here. And of course, because we're researchers, we don't want to just create the thing. We want to figure out, does the thing move the needle? Do we actually help people learn? Do we actually improve comfort with working with this population, or referring this population, or identifying this population? And those studies are kind of underway, where we're trying to do some programmatic evaluation in different kind of learner groups, in nurse practitioners, and nutrition students, and medical students, and residents, and so on. So we're pretty excited about it.
That's exciting. That really resonates with me. Like I like we were just saying at the beginning of this question, at least, like a lot of us didn't get a lot of training, specifically or specialized training around eating disorders, or what to do, or how to even ask, how to assess for, or be sensitive to the possibilities there. And I think in some ways that kind of contributes to this feeling of inadequacy. As me as a therapist, I don't, even if I have a client come in with, some eating disorder symptoms or something going on, I don't even know what to do, right? Yeah. Like, I don't know what to ask, or
that's actually, or what not to say,
or what not to say, right?
Even more importantly.
That's one of the, I think in running through the modules for you, I even forgot to list that one. There is a module on assessing, which is like what to ask and how to ask it, and how not to be afraid to ask it. Because you do need some particular pieces of information. And it's not unusual when someone, will call me about a referral, and I will ask them some follow-ups about the patient, and they'll sort of say, oh, well, I didn't ask that. I didn't know if I could, And we want people to feel empowered, right? Kind of like many of us have along the way in our training learned that asking about suicidality, for example, is important, right? And we need to not be afraid to ask that first question or the follow-up questions, right? Like we actually need to know in order to be able to help. So some of these things, I think, like even tell me a little about your weight history, right? Can feel like very sensitive information sometimes, and yet
very invasive.
It's essential, right? We really need to understand some of that to have some ideas of what might be happening psychologically and medically to be concerned about.
Well, and like you said, with questions around suicide, I think sometimes we're worried that if we ask it wrong or whatever, we're gonna plant the idea in somebody's head, or we're gonna make the situation worse. Similarly here, if I'm asking somebody about their weight, somebody that I suspect is already hyper focused on their weight, maybe I'm gonna cause some harm here. And in some ways, I think a lot of us, who are not steeped in this world or doing this work, worry that we're going to do something wrong. We're going to hurt somebody. We're going to mess things up. And so in some ways, I'm going to ask you for some examples here. But one of the features that we've been doing in our show during this season is asking all of our guests about kind of missteps. When did things not go exactly as planned, or went sideways, or maybe you messed up and you kind of resolved that. We've been calling it confessionals, just kind of telling some stories of, and with the purpose of normalizing that we don't have to be perfect, right? Like normalizing the idea that we can do stuff, and we can do things that are good, and we can learn from those missteps and kind of recover from them. So I wonder if you'd be willing to share with us maybe some confessions about working with.
I'm happy to share some of those. Yeah, I think, first, before I confess, I'll tell you just in general, when asking about someone's weight, right, you want to be mindful of your own potential biases or assumptions.
Absolutely.
One of the things I've learned in doing this work is like, we really you can't know unless you ask. Right.
Right.
And you just really want to ask in kind of a neutral tone. If you're not a medical provider who would be obtaining weight, right? Just tell me a little bit about, when did you reach your adult height, and tell me a little bit about your weight history and how you felt at different, steps along the way, and what behaviors have corresponded with different ranges for you if the person's had a bunch of ranges. And that would be kind of your opening bid. My confessions around this are really have to be as a provider who is a specialist. And so a lot of the care that I provide for eating disorder patients involves some type of weight monitoring. And there are good questions being asked in the field about whether that ought to be blind weights, meaning, the patient, when and how to talk about what's happening with weight with the patient, versus open weights. I have been raised here by a group who, for different reasons, not totally worth going into, does it in an open manner. And evidence-based practice is obtaining this information at every appointment. And there have been so many mishaps along the way in monitoring people's weights because things happen, right? So I have had a patient step on a scale that turned off the moment she stepped on it. It was a digital scale, and it just broke. Right. And here is somebody who is very afraid, this happens to be an underweight individual, very afraid of becoming fat. She's engaging with me around improving her weight and nutritional status. And she steps on this scale and it turns off.
She breaks it in her mind, right? Yeah.
And it became a moment where actually something about it broke through to her. It got a smile. We were human in the moment. And I said, clearly I didn't check the battery, right? Here we are. And let's talk about that fear and what do you actually know is true right now?
Yeah.
Right.
And how do we live in the reality versus the fear? And also with the flexibility that, okay, this week we're not going to have this information. How are we going to roll? How are we going to not let it impact your moving forward in the ways that we're going to talk about this session? We also now, in doing telehealth treatment, we sometimes have people have a scale at home that sends us the readout of their weight. And that's introduced a whole other range of,
I can imagine,
of things that can happen. So we've had, for example, some point younger brother steps on the scale, right? And we get a read that's totally different. And then you could come into the session thinking, what's happening here? And really need to be open-minded and kind of get the information. Always when we're collecting information in this way, we're helping people to tolerate that nobody lives life at any one number, that if I need you to step back on it for any reason, the number's probably going to be different than 3 seconds ago, and that's actually, there's something therapeutic there. So I feel like when I was in graduate school, I had one teacher who used to talk a lot about grist for the mill. And I feel like there's a lot of grist for the therapeutic mill that occurs when you're doing that piece of treatment.
For sure. And again, that's unique to this realm, right? That's not something many providers have experience with, but love that as an example of something that can go sideways. It's been interesting. A few of our confessionals have had to do with telehealth and unexpected things that kind of came up. And as we really tried to pivot so fast and meet needs, sort of these unusual things came up that the field had to grapple with, which is wonderful. I mean, I think leaps and bounds were certainly made during this time.
There have been fantastic opportunities with it in eating disorders treatment as well. We're able to see what food somebody has in their kitchen.
Right.
Yeah.
The environment. Exactly.
Or what their setup is like. Where's their, do they have exercise equipment? Are they sitting or standing? For the
is there exercise equipment next to the bed?
Is the setup for, in New York City, we live in small apartments. Well, if you are at risk for binge eating, right, and you're like right next to your fridge all the time, like it's like important to see people's setup to help them think, behaviorally about how do we work with this. So it's had lots of, as you said, I think there's been lots to learn in the things that happen. But yeah, I mean, all clinicians should be expecting things to happen,
And we need to adapt and overcome, for sure. Which it sounds like you did in your really great example. So thank you for sharing that. We are going to, as always, we also like to wrap up our episode by giving our listeners what we call actionable intel, some things that they could do to kind of take what we've talked about or some of the resources we've talked about forward to, immediately try to enhance or improve or augment their clinical practice. So do you have some things you would suggest for our listeners who maybe aren't as knowledgeable in this area, or even for some of those who are, that steps that they could take to put themselves in a better position to work with this population that really deserves the highest quality evidence-based care?
Yeah. One thing I would ask is that for anyone listening who is doing any kind of mental health evaluation, that you just consider adding this category of disorders onto your evaluation list to even remember to ask about, right? Like we always remember to ask about suicidality or self-harm or substance use or, but let's remember to ask about, eating disorders and some of the core features that I described. I think that would be a tremendous actionable step for people to take. There are some resources that folks should know about that might be worth checking out. So I had given you, the name of the one that we've developed here at Columbia called PreparED. But there is also the National Center of Excellence for Eating Disorders, which has a compendium of resources, including for healthcare professionals. There's the National Eating Disorder Association, which goes beyond healthcare professionals to, coaches and teachers. And then there are also, some books out there that are kind of the self-help version of evidence-based treatments that are worth checking out. So that would be Overcoming Binge Eating by Christopher Fairburn, right, which is really the CBT for eating disorders book that we might have a patient read. There's, if anyone listening is working with teens, then it might be the book Help Your Teen Beat an Eating Disorder by Locke and Grange, which is all about family-based treatment and the principles for that. And then I'll just say, if you like the question and answer kind of feel, let me point you towards a book called Eating Disorders: What Everyone Needs to Know. And that's just a good resource with questions with brief answers that can tell you more about the latest in the field, the latest research questions, how to understand different levels of care as they apply to eating disorders treatment. So I think I gave you a little bit of an actionable step and then some resources that can land you with more actionable steps. And I hope that suffices.
So for sure, we will include all of those resources in our show notes too, and links where we can, for folks that are listening, to be able to find those and to have access to those. So thank you for providing those.
And we're going to add on too, if it's okay, Debbie, a couple of webinars that we've done in our CDP Presents webinar series. We did one last year that was kind of a real general overview, and we'll be holding another one this upcoming January. So we'll at least add the link to the one that's already been done as a way to
and knowing that your audience is, military. informed providers. When I was mentioning earlier the idea of adding this into intakes, I think thinking about also just understanding the culture
Right.
that people are in and what expectations around fitness might be, what availability of food might be depending on deployment, or what stressors might be around moving that could play out in eating behavior. You know your population better than I do, but these are all ways I could think about just adding a question or two about these topics, and you may learn something and find a way to help someone that you might not have otherwise even known was going on for them.
So true. Yeah.
Yeah, those are really great suggestions. And I love that you emphasized viewing, putting into context the behaviors within the context of our culture, the context of the military culture, because I think that does absolutely influence. There's not many places that you work or are part of a team where that's a piece of what they evaluate you on periodically, and there are fitness standards and things like that. So it is unique in that regard.
Yeah.
So I'm former Air Force, and in that capacity, I used to do some of our weight management groups, and had some experiences with a lot of frustrations of folks who, again, the standards didn't really necessarily give a fair and adequate representation of their level of fitness, of their ability to do what they needed to do. So anyway, we could go on and on about that,
yes,
but the podcast is wrapping up.
There are many related topics, but I didn't, exactly.
But thank you so much. Thank you so much again for taking the time. Like Kevin said, we will definitely put some links to those resources that you mentioned, especially to the PreparED website, which is so well done, and it is very interactive, very thoughtful and engaging. So definitely kudos to your team. We thank you all for listening and hope that you will come join us the next time. But for now, we will say goodbye, and thanks for listening to Practical for Your Practice.
Thanks, everybody.
Thanks for listening to Practical for Your Practice.
Please feel free to subscribe, like, and share.
Until next time.